Delirium is a sudden change of mental status, which is a common complication among hospitalized older adults that leads to complications such as permanent functional impairment and increased mortality rate. Effective management of delirium is essential for the older adult's overall well-being. However, no standard protocol exists. Therefore, a robust delirium protocol is necessary to provide nurses with guidelines regarding the management of delirium in older adults in the acute care setting.
Our Pico question reads as follows. For older adults with delirium in the acute care setting, does implementing a robust delirium protocol prevent the development of additional complications, including in-hospital falls, pneumonia and UTIs, decreased delirium stays, decreased length of stay, and reduced 30-day readmission rates as compared to those receiving standard care during their length of stay in the hospital?
Search strategy. The process of finding high-quality, evidence-based studies and research utilized Whitmore and Knafel's process. The main search engine used was the Cumulative Index of Nursing and Allied Health Literature, otherwise known as CINAHL. The key terms utilized were CAM, delirium, nurse, knowledge gap, non-pharmacological interventions, sleep hygiene, music therapy, day-night routines, early mobility, sensory impairment, older adults, and haloperidol. Integration of and or was also utilized for the detailed search strategy. Limiters included the study population, the focus on older adults, the publication dates of 2011 to 2021, the English language, if the article was peer-reviewed, if the text was unavailable, and articles were chosen based on the connection to the integrated review purpose, if there was a favorable intervention, and if it was performed in the acute care setting. Findings resulted in 300 plus articles and were reduced to 5 articles per integrative review with the application of the limiters.
In order to develop a robust delirium protocol, I decided to investigate any barriers that nurses may face when using the Confusion Assessment Method, or CAM, or CAM-ICU, which is the gold standard instrument for assessing delirium. Two overarching topics in these 5 studies are barriers to delirium recognition and educational interventions for nurses. Rowley-Coney's descriptive study and Husser's study identified barriers among nurses in implementing the CAM, including the lack of knowledge, the difficulty of assessing intubate patients, and a lack of time assessing patients, especially during a change of shift. Each study has different educational intervention designs. Ramu's study included teaching methods, such as showing nurses educational videos on the CAM-ICU and teaching them how to perform the CAM-ICU. In Belvin and DeGennaro's study, participants were observed while performing the CAM, and their mistakes were immediately corrected. However, their baseline knowledge was not assessed. Spiegelberg's study included the See One, Do One, Teach One method. This, however, was a QI project, and the researchers did not speak to the sustainability of the intervention. Additional limitations stem from the levels of evidence in these 5 studies. 2 studies are level 3, which is promising. However, 1 is level 4 and 2 are level 6. Overall, the results from the 5 studies demonstrate nurses' knowledge gap in implementing the CAM, and interventions to educate nurses on the CAM significantly improved their knowledge, which improved patient outcome.
I decided to investigate the effectiveness of non-pharmacological interventions on delirium patients in the acute care setting. Non-pharmacological interventions are the preferred method for delirium prevention and management. However, which interventions are most effective remain unclear. For this integrative review, 5 articles were reviewed to determine the most effective non-pharmacological interventions used in the treatment of delirium in the acute care settings. The effectiveness of these interventions is to avoid the use of medication being the first line of treatment for delirium. The interventions that were used varied and were also similar across the studies. Both Kahn and Maceda conducted studies involving the use of music and audio to test on the participants. The music was of the participants' choice, chosen from classical, rock, and jazz therapy. They were also given a choice of a few popular audiobooks that they could pick, while also being given a headset to listen with. Viden and his colleagues used interventions testing mobilization, orientation, and sensory impairment. This was shown to be effective with getting the patients in a routine throughout the day to keep them busy. Overall, all 3 studies imposed interventions on their patients based on post-tests that were being tracked using the CAM and ABCDEF bundles. Studies by both Kresovic and Yevchik tested the knowledge and education of the nurses and how proficient their skills were in caring for these patients. The levels of evidence in these 5 studies varied. Kahn and Maceda had level 2s, Viden had a level 3, and Kresovic and Yevchik both had level 6s. Although these were level 6 levels of evidence, there was much to gain from these studies. Among the 5 articles, they all had their individual limitations. Viden's main limitation of his study was that it was not randomized, which can include some bias in the study. Kahn's study had a few limitations, with a small sample size and being that the study did not continue after the patients were transferred out of the ICU to follow up with their interventions. Maceda had a limitation of also having a significantly smaller sample size, which doesn't allow for variable data. Kresovic's study was that the participants were from multiple ICU units, so the generalized population varied, which could skew the results. Lastly, Yevchik's limitation was that the patient-centered care was only performed regarding the study and not tested on a normal basis outside of the home, where the patient is not monitored as closely. The results showed both the measurable interventions and the educational interventions were shown to be effective toward the patients by decreasing the agitated behaviors of the clients. Even so, there are still gaps in the literature that shows that more research is still needed to be done.
Pharmacological interventions, haloperidol. Across the 5 articles reviewed, prevention and assessment were emphasized in the treatment for delirium. Muniz and his colleagues investigated the creation of a risk model with the goal to identify the medications found in a patient's chart that commonly lead to altered mental status. This model is not universal and does not fit every hospital's unique needs. Some medication categories that were considered high risk include opioids, benzodiazepines, barbiturates, antihistamines, anticholinergics, and antidepressants. Healthcare workers need to be aware of medications that fall into these categories because they increase development of delirium. Usage should be avoided when possible. Al-Quadib and his colleagues investigated the prevention of delirium through scheduled low dosing 1 mg of haloperidol. Although this low dosage did not prevent delirium, it was shown to decrease agitation in the exclusive population of 68 patients. Both Muniz and Al-Quadib emphasized prevention of delirium, so treatment was unnecessary. Articles that investigated the treatment of delirium were conducted by Zerker, Al-Quadib, Jaramungi, and Fleury. Haloperidol was the pharmacological choice utilized for delirium, but it was also used in the treatment for increasing agitation. Jaramungi and his colleagues identified drug-related problems that came from antipsychotic medication. Antipsychotic medications include haloperidol, as well as risperidone and quinidipine. When studying haloperidol, it was found to reduce acute agitation. This could be compared to the study conducted by Zerker and his colleagues. They aimed to describe the dosages and effects of haloperidol used in the initial treatment of delirium. These patients were also diagnosed with acute agitation. They found higher than recommended doses being administered. This increased the risk of oversedation and was significantly greater for subjects receiving more than 1 milligram per 24 hours. Both studies did not support the usage of haloperidol for delirium, particularly at doses of more than 1 milligram per 24 hours. Overall, it was found that haloperidol is the drug of choice to treat delirium, although it is overutilized and most dosages are above 1 milligram that are being administered to patients. The continuation of administration without delirium reassessment is researched by Fleury and her colleagues. It was difficult to trace the appropriate administration of haloperidol from hospital units. There is a lack of assessment of delirium being documented. There is a large gap in the literature surrounding the pharmacological treatment of delirium. It is unclear if haloperidol should continue to be the first line of treatment. There are no standardized doses, and our integrative review has shown various suggested therapeutic ranges. Along with that comes adverse effects when these doses are above 1 milligram. In addition, the research studies had limitations. The majority of research found was weak, level 6 evidence, and one pilot study. Additional research needs to be completed in order to understand the effects of haloperidol so that safe doses can be determined. Then a standardized protocol can be created in order to educate practitioners and nurses and to safely administer haloperidol to older adults suffering from delirium.